Thank you, chairpersons. So without further delay, I'll start with my talk. So this is on targeted next generation sequencing panel-based screening and diagnosis of bone marrow failure cohort. So this study has been conducted at PGIM Chandigarh. Obviously, there has been referral of certain cases from AIIMS Bhubaneswar and other areas. So bone marrow failure, as we all know, is conditions characterized by hypocellular marrow resulting in clinical significant cytopenias in one or more hematopoietic lineages, and they can be further divided as primary or inherited and idiopathic and secondary. And suspected inherited bone marrow failure syndromes may or may not be associated with distinct phenotypic or constitutional abnormalities. And currently, there are more than 120 genes which have been associated with different inherited bone marrow failure syndromes. Also, if we look at aplastic anemias per se, around 4 to 5% of clinically diagnosed idiopathic aplastic anemia may harbor a silent germline variation in one of the genes related with inherited marrow failure syndromes. And identifying the specific mutation is required, aids in not only establishing a diagnosis in IBFMS, predicts the disease outcome, directs genetic counseling and treatment, and also helps in selection of healthy sibling donors for hematopoietic stem cell transplant. On the other hand, screening cases of idiopathic aplastic anemia for different IBFMS gene helps in it's very necessary because it changes the treatment per se and also avoids toxic pre-transplant morbidity. With this in background, and next generation sequencing, as we all know, helps us in multiplexing a lot of different targets and pulling in a lot of different samples. Moreover, there's very patchy data from our subcontinent regarding bone marrow failure. It's primarily confined to individual cohorts of small cohorts of Fanconi anemia or DBA per se, but not a comprehensive next generation sequencing evaluation. So the current study is basically a 4-year experience in not only diagnosis of clinically and or based on family history suspected inherited bone marrow failure syndromes, as well as on screening of idiopathic aplastic anemia cases, either starting the IST treatment or pre-transplant, using a custom designed panel, which is just made of 33 genes based on NGS, and to highlight what is the frequency of different variations and how this custom panel is helpful in diagnosis. So the study design is there's both pediatric as well as adult cases, age ranging for pediatric at our hospital are till 12 years, and above them we considered adolescent, younger adults, and up to 50 years of age. This is a 4-year study, as I highlighted. So we did targeted NGS based on this panel. So this panel on the extreme right-hand side is what we curated from literature in different OMIM and other databases available. And it covers the most important genes which are related with Fanconi anemia, dyskeratosis congenita, Diamond-Blackfan anemia, congenital neutropenia, congenital thrombocytopenia, Schwarzman-Diamond. Also, many newer genes which are related with myeloid neoplasm predisposition, that is ETBS6, RUNX1, DDX4, GETA2, your ANCA D26, and the lately described MECOM, URSICL62, SAMD9, and SAMD9L. And we performed this in the cohort of 171 cases, both adult and pediatric, and we divided them into 2 groups. The group 1 was those that were clinically suspected as inherited bone marrow failure based upon the clinical examination, the laboratory tests based upon the constitutional abnormalities and or family history. And the cohort 2, which was primarily idiopathic aplastic anemia cohort, which was either pre-transplant, pre-IST, screen, or cases which were non-responsive to IST at 6 or 9 months of treatment. And the further the numbers in the pediatric and adult cohort are highlighted. We also performed whole exome sequencing, but in a very limited number of cases which were either negative in cohort 1. So this table highlights both the groups, the data for both the groups, and I'll go sequentially in the important findings. So the mean age for pediatric cases in group 1 was 4.4. In the aplastic anemia cohort, obviously it was 8.3, whereas the male to female ratio, it was more skewed towards the male in both the cohorts. In group 1, isolated anemias were the most common, whereas in the pediatric population, in adult pancytopenia cases were more common. On the other hand, if we look at the extra hematological or the constitutional abnormalities, so we had dysmorphism as most common in pediatric, whereas nail, skin, and hair changes were more common in the adult IBFMS group. Also, if there were cases with family history which was positive in both pediatric as well as adult cases. Further coming briefly to the results. So if we look at the right hand side, the chart above, the overall targeted NGS positivity, if we excluded the VUS or the heterozygous single allele cases, in IBFMS was 46%. And if we divide them further into pediatric and adult cohort, it was around 41% in pediatrics and 55% in adults. So adult suspected IBMFS had a relatively higher diagnostic yield. On the other hand, in IAA cases in which we screened, so overall positivity was 12%, in pediatrics it was 19%, and in adults it was 6%. WES, which was performed in only 15 out of 59 cases, which were either negative or VUS in cohort 1, we had positivity in only 3 cases. That is, it could only aid in diagnosis in 20%. If we look at this distribution of different diagnoses in different groups, so in pediatric IBFMS cases, DBA was the highest, which showed mutation positivity, nearly 34%. In adult side, it was the MDS and AML predisposition genes, which had much more common as expected. Also DC, many cases of dyskeratosis congenita presented in young adults and adolescent. In pediatric IAA, it again MDL, AML genes, which were quite silent in the IA cases, were seen. And in adult side, it was Fanconi, which was more silent. So if we look at this oncoprint map, so we have both the constitutional abnormalities on one aspect and the different genes, and we have clubbed the cases down in the x-axis. And if we look, the constitutional abnormalities were present in nearly 50% of cases of DBA and dyskeratosis congenita, but as nearly 70% cases of Fanconi had one or the other constitutional abnormality, especially short stature and hyperpigmentation of skin. So MDS AML predisposition gene positive cases were total 13 cases. Out of them, 10 were in IBFMS group and 3 in IAI group. And 79 mutations were the most common, which we identified in 7 cases, followed by MECOM in 3 and SRP72 in 2 and GATA2 in 1 case. So further, if we look into how much of our cases were clinically classifiable in IBFMS group, that is cohort 1. So clinically classifiable 42%, whereas unclassified were around 58%. And if we look at mutation positivity in each of this, so there was not much difference. So in both clinically as well as unclassified cases, the targeted panel could have a pickup of 44 to 51%, which was nearly similar. So this is the table highlighting the IIA cases or the cohort 2 per se, and we can see here there are a lot of silent cases which were positive for SAMD9 or MECOM mutations, which are usually not expected. So we ideally need to screen out our IIA cohort and look for these cases. There have been now multiple reports coming up from Western literature data about the heterozygous variants in their relation with bone marrow failure and aplastic anemia. And they have also shown association with severity of aplastic anemia, but yet response to IST has not been noted. Our 3 cases which were positive for SAMD9 all had delayed response at 6 to 9 months. So it needs to be further see in our particular cohort how they behave further on longitudinal follow-up. So the literature data on other targeted panel is, if you look at, so the targeted panels in different literature have a positivity in both clinically classifiable and unclassifiable, varying from 30% to 43%. And whole exome does not really add on much to the diagnosis. Its positivity varies from 6% to 12%. This is another study from Japan, which shows only whole exome sequencing, which is aiding just 11% to their further diagnosis other than the targeted panel approach. And this is the nutshell our findings out here. So overall targeted panel in IBFMS, your diagnostic yield will vary from 35 to 50%. It all depends upon how best you have curated your panel or how best you know your panel, because there are a lot of cases. If you include more of DBA cases, obviously 40% of them don't have any mutation as yet identified. So your positivity would fall down. If you have more of severe congenital neutropenia, again, your positivity would fall down. Also, you are not going to look at deep intronic. You're not going to look at other, large CNVs in these genes by NGS. So your positivity may vary from panel to panel. So in summary, our targeted panel has an overall diagnostic yield of 46% in IBFMS cohort and 12% in IA. This is in line with most studies and literature. And if we look at clinically unclassifiable BMS group, the difference is not much. It's around 44%. Limited whole exome did add 12 to 15%, but not much. Thank you.